So our next speaker is Dr. Anna Brooks. She's a senior lecturer and director at Auckland Cytometry, University of Auckland in New Zealand. Her topic is New Zealand's long COVID landscape, from recognition to biomedical research, an overview. We are very pleased to have you here with us, Dr. Brooks.
So thank you so much for the opportunity to join this amazing initiative that you guys have launched here. So I'm going to give a bit of a whirlwind tour, sort of covering off our situation through the pandemic and essentially where we are today. So a bit of history about me. I'm an academic researcher at the University of Auckland. I'm an immunologist there, and I am also an expert flow cytometrist, hence the director of the facility there. So I'll sort of touch on near the end the assays, or essentially the research that we will be, or that we are undertaking. So, right, just to kick in, I kind of wanted to actually start off right from the outset, acknowledging this whole aspect of uniting to fight, and that we are all in this together. This essentially was such a key point all the way through this pandemic, from the very beginning when we saw it unfold right through to today. Meaning, you know, everything from every aspect, as from being a researcher in this space, from being a patient advocate, speaking to the media, and so on and so forth. And what I'm sort of demonstrating on this slide here is that I really do sort of mean, in the context of the research that we're pursuing, that everyone is inclusive in the work that we are sort of aiming to do, because there are so many unifying features of many of these conditions. And so that's sort of one of my goals, is to target research in the space of sort of the unifying feature. So I sort of wanted to sort of launch in really sort of highlighting the significance of uniting to fight for recognition and moving things forward. And also sort of noting here, you know, New Zealand is a teeny tiny little island on this global map. And in fact, sometimes we're even missed off maps. So it was nice to see that New Zealand is here. And we do know that we were very much pedestaled and looked really great right the way through the pandemic and our pandemic response. And yet, because we are sort of in the middle of the ocean, if you like, it often does feel like that we, you know, where we are now is not necessarily, or is still sort of, we're still sort of shining from that. And absolutely, we did a fantastic job during the pandemic. But what I'm going to walk through now is that there's so much we should and could be doing in the space of recognition of long COVID and post-viral illnesses in general. So, and again, I just wanted to launch in from the outset to recognise, you know, how we've pursued advocacy in New Zealand and the research. And today, I'm sort of proud to announce that we've sort of relaunched actually our patient-centred research platform. So our website has hopefully gone live. If it's not active right now, it should be in the next few days. It seems a little bit glitchy, but we were pushing out all the stops to get it live this evening. But essentially, on our website, you'll sort of see sort of the premise behind what we're trying to achieve. And again, you know, the term disimmune, it's not even really a true word, but I'm sort of coming from that place that we want to understand essentially the dysfunction of the immune system. And as I sort of showed on that slide earlier, the unifying features across a number of conditions. You know, a key premise of this foundation, or of our website and basically this initiative, is that it's patient-centered. It's for patients. We came together to you know, push this forward, and it was all, for me, it was all about connecting with patients and understanding what those priorities were. And indeed, for New Zealand, some of those priorities were very different from the global perspective, pretty much due to the different trajectory that we went through. For example, early on, one of the key aspects that was really driving the research was understanding, or basically identifying whether people had been infected or not during the early stages where testing was not widely available. And so that's sort of stuck with us, and do, as I say, feel free to jump in there and have a look, because essentially what you'll also learn throughout the rest of my talk is that, we have pretty much lacked any biomedical funding dedicated to long COVID research in New Zealand. So we've relied on crowdfunding to keep momentum going. So I just wanted to start from that perspective. So I'll now sort of just walk through just a quick summary of our pandemic response. We know that, as I said, it's a world famous response because we did so well. However, where we are today is sort of is most important, really, I guess. So a quick flick through, we've got a population of around 5.3 million. The cases reported over during the time that they were being reported was, about half our population. And just like everywhere else in the world, reporting has pretty much stopped, and we monitor the situation through our wastewater. And absolutely, we are very proud of the fact that we had an absolutely a low mortality rate due to our very strict pandemic response and our vaccination strategy. And indeed, recent publications have even showed that we had a negative excess mortality during 2020 and 2021. So we saved lives, absolutely. Our vaccine response, we also had, high, what is basically framed as a high vaccination rate. What that's really referring to is the primary vaccination rate. This was largely facilitated by mandates and our lockdowns as well, which sort of made it easy for people to get out and get vaccinated. But essentially from there, that's petered off, which I'll show you in a moment. Booster uptake has been fairly good in the vulnerable, though. And on the whole rollout of, another aspect is that the rollout of any of the updated boosters has been slow here. And that maybe part of that is due to lack of interest, which also seems to play a role in vaccine uptake as well. Another thing to sort of point out, though, that is probably similar to other countries, is that we do have a relatively low vaccination rate in children. So less than 40% have at least one dose. And in fact, the absolute numbers are actually difficult to find. So this little snippet here that I have clipped off one of the websites is around about 20-ish% are fully vaccinated. So that's one of the reasons there was that the eligibility of children or over 5 to 11-year-olds came into effect as our first real wave hit the country, which was Omicron. So these aspects have all sort of played a role. So where does that leave us with long COVID? So, essentially this is, the part of the response that, we really haven't paid much attention to in this country. Nothing like the amazing first part of the response where we were saving lives. And that's nothing surprising, and that pretty much globally it was all about the severity of illness and keeping people out of hospital. So that sort of played out here too. So we don't have a very good prevalence estimate. We're not really tracking anything, tracking any numbers, and most of our long COVID burden is from the Omicron waves due to our lockdowns. As I've mentioned, there's been no dedicated national funding efforts for clinic, basically any clinics. We're hearing that funding is drying up internationally. It never happened here. So we've never had any dedicated clinical pathways for people to access. And we've never had any dedicated biomedical funding research either. We have had some funding, it's been limited and has finished as well. So in short, it's been very difficult for people to access support. And that's where we are today, that we still need to raise awareness and keep pushing for recognition and acknowledging that this is a global burden that we should be paying attention to. And so again, just sort of flicking through the picture here and why New Zealand looks, somewhat different or interesting, and why we should be paying attention and documenting the history that's gone on here. This is just sort of showing you, the vaccine rollout. And essentially, New Zealand's population was highly vaccinated before our unmitigated transmission occurred. And here you can sort of see the rollout of the vaccines. We had huge responses essentially because we were in lockdowns, and then sort of a bumbling along since then. And if I overlay on top of that, essentially not to scale, but this is sort of overlaying when COVID really hit our country. So you can see that there was a lot of vaccination had already happened. Some people have been boosted, but essentially, this played a massive role in where we are today, because, that's potentially going to change our long-term health burden if we were indeed tracking this more closely so that we could actually document that. And if we look at where we are today, we have a very interesting picture, because COVID has not gone away. It is still with us, and it's still going to continue to cause health problems, including increasing cases of long COVID. However, we've seemed to have fared okay despite the waves of the new variants hitting our shores still. So as you can see from this graph, which is up to today, the blue line is our wastewater, which is the only reporting that now happens. And you can see, we've had some little bumps along the way since JN.1 and even XBB hit, but we're not really getting any of these substantial spikes. So it seems to be that, we are doing okay in that regard. However, we don't really know what this all means. And it's a shame and a lost opportunity that we haven't been tracking this more closely, especially biologically, so we could learn from this. So if we look at New Zealand's landscape and, when the cases first hit our country, there were many waves before in almost every other country. There was a ton of waves. So the big question here is, that we know that most of our infections were due to from the Omicron waves. The big question is, will our long COVID burden be lower? We won't really know until we start tracking formally. Will our long-term health harms be lower? Or are we just many waves behind and this will just catch up on us? We really just don't know. So our initial pandemic response saved many lives, but long COVID has never really been a priority here, and we're continually pushing in the advocacy space because we still have so much work to do. So just a quick whiz through here in the interest of time. There is a long history of ME research in New Zealand, going back even into the 80s. Dr. Les Simpson was renowned for his early work identifying or recognizing that deformability was playing a role in this illness way back then. And as we know now, that could, that is part of some research that goes on today. Just sort of noting that one of our Associated New Zealand ME Society, ANZMES, was the first charity in the world to be established in 1980. We also were recognised for a 1984 outbreak of Tapanui flu, and essentially, since those days, there's been research going on in this country. Emeritus Professor Warren Tate has been doing research for many years, and now obviously, into long COVID as well. And there's many more other people, significant people in our country that have been fighting for recognition and research. However, despite all this history, there's still so many barriers for adequate support, including research support and access to clinical care. And so this is now including long COVID. And so, again, just sort of identifying here that we've got a number of support groups basically doing all the work, providing all the support with very little funding, or pretty much no funding really. So there's a lack of dedicated funding out there. We're still lacking, comprehensive training in our medical schools, much like many other places around the world. But really, it's just sort of, I'm just highlighting here that, there's so much work that we need to do in the space of long COVID, despite the fact that during the main part of the pandemic response, we did so well. So I won't go through this slide really because, you know, we have covered off the key hypotheses across many of the presentations so far. And I just wanted to hone in sort of where I'm centered and what I'm sort of focusing on in our research here. So as I sort of said, we've covered off, you know, all the key aspects. So where I'm really interested in honing in on is the immune dysregulation or dysfunctional state that may be happening in the immune system. And as we know, there's been a ton of beautiful studies in this space already. And so again, I won't sort of touch on those, but I'll just sort of hone in on some of the key aspects that I'm interested in. So I've sort of left on this picture here the sort of integration of mitochondrial dysfunction, which we know has again been identified in some key studies, at least in the muscle and in historical studies as well in immune cells. But I'm sort of wanting to sort of look at this from a different perspective at a single cell level to sort of really understand, you know, can we identify anything more in the blood using sophisticated or tools to do so. Just a quick flash through here. What I'm really just sort of proposing is that, you know, there's been elegant studies looking in deep detail at the adaptive immune system and, you know, whether there's a dysfunction there. Essentially, you know, we've got a great handle on that. What I just wanted to highlight here also is that I'm sort of wanting to continue on in this space by looking across the entire immune system and looking if there is any signatures or anything going on in the innate side as well. So again, I'll just flick through this quickly, but essentially, you know, the innate system also plays a key role in shaping the adaptive immune response. So I'm sort of asking the question or wanting to pursue, you know, is there anything happening on the innate side that is triggering any of the dysfunction or overstimulation, exhaustion, all those sorts of things that have been published to date. And that's where I want to sort of sink my teeth into. So I won't sort of labor on this because in the interest of time, but essentially the technologies that I'll be using is doing a deep dive, deep immune profiling using full spectrum flow cytometry, because this really allows for a really intricate look at all of the immune cells in whole blood especially. So we've been doing whole blood profiling already, and that work is ongoing. So I haven't got the analyses today, but there's some interesting results being shown already. And so once we've done the whole immune profiling, which is looking across as many cell populations in the blood as possible, we will then go on to do sort of more of a deeper dive across the innate lymphocytes as well, but essentially just sort of doing this deeper dive to ask a little bit more deeper questions, I guess, or not just immune phenotyping, but also functional as well. So I just want to touch on sort of where I sort of sit with, it's essentially a hypothesis. We absolutely know there's nuance in immune dysfunction. You know, we know that not every single person is getting sick every time they're exposed. And on the other hand, we know that some people get sick every time they're exposed. So there's obviously some, or there is likely to be some sort of trajectory involved here where we might get infected and then have a recovery phase. And we don't know how long that recovery phase may be, but at the same time, we may get another insult along that recovery phase that then triggers our illness. And I just want to sort of acknowledge here, this sort of hypothesis that I'm overlaying here as immune dysfunction completely is sort of aligned with our collaborators at Murdoch University or the Australian National Phenome Centre, Professors Jeremy Nicholson and Julian Wist, who we're collaborating with, where they've got an elegant hypothesis there in their research where they're showing metabolic disruption. So essentially, I'm sort of overlaying that I sort of see that the immune system could be having a similar trajectory like this, where if we can start to dissect what's happening in the immune system and whether we can find biomarkers in cell function, we might be able to start to unpack what's going on here. So as I sort of referred to, there's metabolic dysfunction. But essentially, what I'm sort of proposing here is maybe that there's an immune vulnerability state that might be able to be identified if we're using sort of a deep dive approach with immune profiling. And what I'll touch on just briefly in a moment, also metabolic single cell immune profiling, because I think this is going to be really, really important in the context of understanding why different patient groups are responding so differently to vaccination, for example. And I think this will help inform vaccination strategies for people with ME and long COVID moving forward too. So that's the hypothesis, essentially, in a brief nutshell. So this is just sort of this summary here. Just finishing up now, but essentially this is a brief overview of the strategies that we will take, that we want to do a deep dive and look at the proteins in the blood using the metabolomics with the team in Australia, and then do a deep dive on blood cells, looking at not just immune phenotyping, but single cell immunometabolic function using these unique flow cytometry assays that are looking at the single cell level. And finally, we want to overlap that with the work of Dr. Martin Krater, who we'll hear from shortly, in the deformability space as well. So that's essentially, wrapping up here. The big question here is, are we unique? And we have got samples that are banked. We've got a unique demographic. We've got all of the know-how, and we've got these samples stored. We're just sort of lacking the resourcing to accelerate this work, which I think is now becoming a global issue because of the somewhat political state we're in, and the lack of resourcing going into long COVID now. So just in summary, essentially, I've just sort of wrapped up all of this. There is an urgent need for ongoing support in our country, much like the rest of the globe. And we want to join the fight too. We can join the fight. And so hopefully in due course, we will be able to accelerate the research and investigate our hypotheses with our New Zealand demographic to help inform studies globally. And with that, I'd just like to thank everyone, and a huge shout out to the patient groups, especially Dr. David Davies-Payne and Rohan Bodaka for their support too.
Thank you so much for your super informative presentation, Dr. Brooks. Now I'd like to present you some questions from our attendees. So the first question is, I've seen very little on SARS-2 prevention or LC treatment and care from the established non-state actors and NGOs in health. For example, 217 in special relations with the WHO. How can the COVID-aware community improve their advocacy and voice and impact?
In prevention, was that the beginning of your question?
Yeah. So the last question was, how can the COVID-aware community improve their advocacy, voice and impact?
I think it's going to be an ongoing challenge. Absolutely, trying to prevent more long COVID and prevent. This is what we're trying to do here, and raise awareness that this is an ongoing issue. I guess we just have to keep at it. We just have to keep our voices heard, really. There's no really easy answer to that.
Thank you. So the next question is, do you believe that including those who have suffered long COVID symptoms post-vaccine should be included in these studies? There seems to be a lot of crossover.
Yes, absolutely. I think it's very much worth seeing and understanding whether there's the same biology or different. So yes, essentially that was sort of my message at the beginning, that the types of assays that we're developing, once we've got the key sort of preliminary data, then we can start to compare to all the other types of scenarios to get an understanding of the common ground across. Yeah, absolutely.
Thanks. So Ursula is asking, what is your assessment of the danger of reinfections?
Well, it's a good question. I think as I sort of alluded to, I think it's very nuanced. I think that reinfection could be dangerous for us all, absolutely. There's no denying that. But I think the nuance is whether you feel it, right? So for some people, that reinfection is symptomatic every single time. And, you could be getting worse every single time. And then there might be people who are re-exposed, asymptomatic, and don't have symptoms, and therefore it might be years down the track that there's harms from that. But essentially, I think, yes, the way I see it is that any one of us are at risk at any one time. And we just don't know what our risk profile is. But my nuance to what I believe sort of happening immunologically is that I think that we have a risk profile in the context of that becoming symptomatic. And we just don't know what's controlling that. So we don't know when we're at risk, essentially.
What do you think about the influence of the neuroinflammation on the immunologic system?
Yeah, absolutely. The neuroinflammation is a key part, absolutely. I mean, there's lots of beautiful studies coming out, trying to unpack what's going on there, and whether there's, inflammatory mediators or cells or the, immune cells in the brain itself. But yes, I believe that's playing a big role as well. So we're not necessarily, going to get those answers in the blood per se. Obviously, there'll be other ways to do that. But yes, I believe that it's all part of the picture. Yes.
Thanks. Good. Then another question. So I have an appointment with hematologist on Friday. What specific questions should I ask them? I'm in Hawaii and some doctors don't know what LC is. Thank you for your help.
It's very difficult. It is very difficult unless there are any, specific tests that can be done, especially immunologically. There's nothing very clinical or clinically clear from an immune perspective. I think it's an ongoing challenge, especially if the doctor you're seeing is not aware. Yeah, I think it's difficult. I get that question all the time here, and it's a difficult answer depending on where you are around the globe as well.
Definitely. Okay, then what do you think is the cause of the apathy in New Zealand regarding long COVID? Is it politically influenced or from the Ministry of Health?
It's difficult to know exactly. I mean, I guess it's one of those scenarios. It didn't sort of surprise me, I guess, is one way of answering that, if you count a problem, you've got to do something about it. So that's one way of looking at it. It's a financial cost, I guess, as well. So, yeah, I mean, it would be nice to know exactly why. There's been sort of a lack of want to, recognise this. But it's been a huge challenge. I will say one sort of other point is a big shout out to New Zealand media. New Zealand media have largely been supportive on the whole. So we've had that part, we've had the recognition, being disseminated that way. So not always, but, mostly they've been supportive. But yes, we don't really know why exactly.
Not to tell. Okay, then Martin asks, are you screening for PAM and ME/CFS?
Yes. So essentially, when people sign up for our study, yes, they acknowledge whether they've had a diagnosis and how they've had a diagnosis of ME/CFS, and so on. Yeah, it's all sort of part of the screening. Yep.
Then another question. The immune cell profiling is really interesting, especially if you can conduct it just with blood samples. Would that mean you could scale it up if you had the resources? How many samples would you be able to process?
Well, you can, as in how many cells in the sample or how many blood samples? What scale up?
Not quite sure how it was meant,
Mhm.
but it helps you. I can reread the question if it
Yeah.
helps you. Okay, so once again, the immune cell profiling is really interesting, especially if you can conduct it just with blood samples. Would that mean you could scale it up if you had the resources? How many samples would you be able to process?
If it's number of samples are, limitless with resources. If it's in the context of how many we can do, I think if that's what that means.
Then one last question. Are there reference values for antibodies after vaccination or after infection? And what can I do if the antibodies are under reference values?
So are there antibodies after vaccination?
Yeah, after vaccination and after infection. So both, if there are any reference values. I think a limit you're above or below.
As in to confirm COVID? Is that what the antibodies are inferring? Maybe.
I'm sorry. Maybe. Yeah, it wasn't more precisely asked. That was just a question. Okay, but I'm also seeing we're running out of time for the Q&A session, but nevertheless, thank you so much for answering all the other questions. And once again, thank you for being with us today and spending your time with us. It's highly appreciated.
Thank you.